When we talk about the cost of cancer, you probably think about the price of a single drug, right? Well, a recent study digs into this, and it turns out it's a much deeper, more complicated story. So today, we're going to translate all that dense economic data into what it actually feels like for a patient going through treatment for advanced lung cancer.
And that really gets to the heart of what we're talking about today. What is the true cost of surviving cancer? Because as we're about to see, it's not just about the money. It's about time, it's about endless clinic visits, and it's about the ever-increasing burden that patients face as their disease gets worse.
Okay, so to really get what this study is telling us, we need to get specific. We're not talking about all lung cancers. The research zooms in on one very particular type, a cancer that's driven by a specific genetic hiccup.
We're looking at something called EGFR-mutated non-small cell lung cancer. Now, what on earth does that mean? Well, think of a protein called EGFR as the gas pedal for your cells. In this type of cancer, a mutation basically jams that gas pedal to the floor. The cancer cells just grow and divide, completely out of control.
And this isn't some super rare thing, you know? This specific mutation shows up in about 17% of all patients with non-small cell lung cancer. So yeah, figuring out how to treat this is a really big deal.
So for these folks, their entire journey starts at this one crucial fork in the road, the very first treatment they get. And that single decision, it ends up shaping everything that comes after. The study really zeroes in on two main starting options. On one side, you've got osimertinib, which is a modern, targeted therapy you take as a pill. And on the other side, you've got your traditional platinum-based chemotherapy, or PBC, which you get through an IV drip. A pill versus a drip. It sounds simple, but that difference has massive implications. Okay, quick sidebar here. We need to get a term straight. Lines of therapy. Think of it like a series of battles. First line, or 1L, that's your first attack on the cancer. If the cancer starts growing again, that's called progression, you move on to second-line therapy. And if that stops working, you go to third line, and so on. Simple as that. And this is where the study uncovers its most powerful and kind of tough finding. As patients are forced to move from one line of therapy to the next, they run smack into a wall of diminishing returns. Just look at the clock here. On average, that first-line treatment works for about 10 months. But watch what happens. When a patient has to switch to the second line, the time they get on that treatment drops. By the third line, it's even shorter. With each progression, the treatment is buying you less and less time. And now, here's the economic gut punch. While the time you get from the treatment is shrinking, the monthly cost of care is doing the exact opposite. It's climbing, from almost $28,000 a month at the start to over $31,000 by the third line. I mean, let that sink in for a second. You're paying more money for less time. So there it is, the single most important finding in the whole study, stated as plainly as possible. For these patients, every new line of therapy was shorter and more expensive than the one before. It's an incredibly tough reality, and it puts a huge strain on everyone involved. So let's circle back to those two paths we talked about at the beginning, the pill versus the chemo drip. Because as the study shows, that initial choice creates two very different stories with very different burdens right from day one. Okay, check out this tale of two treatments. The osimertinib pill gets you almost a full year of treatment time, on average. That's double the 6 months you get from chemo. But, and this is a big but, look at the visits. Chemo means about 8 trips to the clinic every month. The pill is half that, but still, 4 visits a month is a lot. So while the pill costs more each month, that extra time it buys you is absolutely critical. So where is all this money actually going? Well, for patients who start on the pill osimertinib, it's probably no surprise, right? The pharmacy cost, the price of the drug itself, is the biggest slice of the pie, almost 60% of the total. But now, flip over to the chemotherapy path, and whoa, it's a completely different story. A staggering 88% of the cost comes from outpatient services. This isn't the drug itself, which is relatively cheap. This is the cost of everything else. The clinic's time, the nurses, the IV setup, all the resources needed just to get the medicine into the patient. And, beyond these big numbers, the study really pulls back the curtain on the hidden burdens. I mean, even if you're just taking a pill at home, you're still in a clinic about once a week. And for those same patients, if the cancer progressed, their monthly costs jumped by almost $9,000.
And maybe the most telling detail of all, late in the game, about 1 in 10 patients were getting immunotherapies that aren't even recommended for this cancer, which just screams that there aren't enough good options left.
So what does all this add up to? What's the big takeaway? It all boils down to one simple, incredibly powerful idea: the value of starting strong.
I'm just going to read this quote directly from the study's conclusion because it says it all perfectly. Findings highlight the importance of using the most effective 1L treatments to delay disease progression and reduce healthcare resource use, that's HRU, and costs.
So here it is, the bottom line. Getting a longer, more effective first treatment isn't just about buying a few more months. It's about pushing back that incredibly difficult transition to later stages of care, stages where the treatments work for less time, cost way more money, and just take a much bigger toll on the patient.
And that leaves us with one last big question to chew on. We are developing these amazingly smart, targeted therapies. The science is just incredible. But this research forces us to ask, as the treatments themselves get smarter, how do we build a system that makes sure the care also gets better, more efficient, and at the end of the day, more sustainable for every single patient who needs it?